Hello everybody, this is Dr. Kevin Connors. We're going to go over what I'm calling Labs 101, why we should run standard blood tests, why it's a good idea even if I'm out of the medical system, my doctor said they're all normal, I need to get, deeper. It's still important to run standard blood tests and put them into a software or talk to a practitioner who knows how to read them differently. So let's talk about that. It's really important to find a practitioner that's going to dig to find the reason why. If you're not feeling well, you're, having ill health of some kind, there's a reason. So I can't tell you through the course of 35 years of practice that how many years? It's been more than that now. Holy moly. That how many times I've heard people say that their doctor told them that they just need to get on an antidepressant or they need to go to a psychologist or it's all in their head. And that's really unfortunate because I'm going to show you even a recent example of tomfoolery in the medical profession here in this presentation. I'm going to jump into it. But let's get some basics here first. For the purpose of a functional blood chemistry analysis is really to figure out what is going on. What is the dysfunction? Where is it? Where do we need to look further? Where do we need to dig further? And standard blood work, and by that I mean the standard what your medical doctor may run, a CBC and a complete metabolic panel, can tell us, give us clues. And that's really what any test is, whether it's, the gold standard PET scan and gold standard CT scan and MRI with contrast and things. They're just tests that give us clues. Nothing's going to be perfect. Even a biopsy is never going to be perfect. You have to put all these things together and to come up with a working diagnosis that can change. And there's comorbidities that go along with this. So what are some of the sources or causes of the dysfunction? What specific treatments should we start with? And then to retest to show that things have been restored and that we made changes. That's the purpose of this. So there's a lot of good reasons to do regular blood testing to see, first of all, things can change quickly and you want to be on top of that. I just spoke to somebody this morning that had anemia on their blood, on their CBC, very definite anemia on their CBC. It was done 5 weeks ago. Why didn't the oncologist order? This should have been ordered like 2 weeks after that test. So when a person has significant abnormalities on a CBC and complete metabolic panel, tests should be run at least monthly to look at the treatment parameters that you're doing. Has this person, is it working or is their condition deteriorating? And I need to be on top of it before they're in the emergency room running a blood test. It's just ridiculous why that oncologist, seeing that this person had irregularities in their complete metabolic panel as well as anemia in their CBC panel, why he didn't even order another blood test. It should have been ordered for 2 weeks out, at least at the very maximum 1 month out, to recheck their condition to see if they're deteriorating. What we need to make some adjustments to the treatment plan. He didn't even address it. But you see this all the time. You see this even with functional doctors. They're not addressing it. So you have to catch dysfunctions that are easy to correct if caught in time before it becomes an emergency room visit. Need to screen also for prescription drug related issues. So if you're on a prescription drug, which many people are, that can affect your blood work. And if it's affecting your blood work in a negative way, you might want to change the prescription or talk to the prescribing doctor. Even supplements can have effects negatively on your blood work, and we want to know those things. Now, understand there's two different ways to look at your blood work. There's looking at normal reference ranges that are given by the labs. And these will often be, you'll be in the normal reference range, but you'll be at the top end of the normal or the low end of the normal. The normal reference range is not something that we want to look at from a functional perspective. And I'm going to give you an example in just a couple minutes. But the normal reference range is the average. It's not optimal. If you're at the high level of normal reference range for, let's say, TSH for thyroid function, you probably have thyroid issues. We need to have an optimal range or a functional range. So we don't use standard normal reference ranges. We want to use optimal or functional medicine reference ranges to catch things before you're in an emergency room situation. Besides, normal changes from year to year. It changes from lab to lab. On an example of white blood cell count, for one lab, normal might be 4 to 10.5. Another lab uses 4.5 to 11. Another lab, which you're going to see in my example, a hospital lab, did it 4.5 to 13.5 or something like that, which is just absolutely ridiculous. So it just changes. You don't look at normal reference ranges. You want to look at optimal reference ranges, or what are called functional reference ranges. So a functional reference range is going to be much tighter. Optimal reference range is going to be much tighter. Here's an example. U.S. labs have normal TSH, that's your thyroid stimulated hormone reference range, of 0.45 to 4.5. Some labs have it 1 to 5.5. Again, labs have different reference ranges. And early in 2001, this is 20 some years ago, the American Association of Clinical Endocrinologists stated even though a TSH level between 3 and 5 is within the normal range, see, their range is different than what's given by most labs, it should still be considered suspect since it's a signal. It signals a case of evolving thyroid underactivity. So shouldn't you catch these things before they become way outside of the quote-unquote normal range? That's the whole idea of functional medicine. We want to catch things before they're in a complete disease state where it's very difficult to do anything about them at all. But it's so often that we will look at a person's labs that they were told that they were normal, and they were even not normal within the normal reference range. It's like the doctor just didn't understand it, didn't go over it because he or she doesn't understand blood work. I have no idea. I'm not here to be accusatory, but it's, why run the test if you don't know how to interpret it? I don't get it. I don't know if I'll ever get it. So blood chemistry CBC analysis is a functional approach. We want to look at a functional approach, an optimal approach, not what's outside of pathophysiological ranges where this person's already in a very diseased state. We want to look at tighter ranges in a functional approach. Okay, I think I beat that horse. So rules in looking at blood work. This is really anything you're looking at, whether it's a CT scan, MRI, X-ray, a PET scan. Never rely on one test. Never rely on one test. A test is going to give you clues. A test can even give you a working diagnosis. But you want to look at trends if at all possible. Now, sure, you have symptoms. You go in and you have a positive CT scan for what the radiologists would deem very possible cancer. Then you get a biopsy and it's positive for, let's say, prostate cancer. Of course, we got a working diagnosis now, but you still want to look at trends. Where was this a month ago? I don't know. I didn't get it tested. Where was it a year ago? I don't know. I didn't get it tested. Perfect example of prostate cancer. This person could have prostate cancer for 5 years and it's staying stable. Do we need to get super aggressive in the treatment right now because now is when we found it? Well, how do we know? Well, slow down, look at other tests, look at the trends, and then you have to compare with other objective tests and other subjective signs. The person has no symptoms, they feel great, they have more energy than they've had in years, and now they're diagnosed with something. Yes, should you address it? Should you look at it? Should you make some functional changes and lifestyle changes? Well, of course, those might be in the rule. Should you get aggressive in care? I don't know. You have to make those decisions. But you never rely on just one test. You want to look at trends. You want to look at multiple different types of testing when you're coming to a working diagnosis, and then you want to begin a treatment plan that is not going to be necessarily too aggressive for the patient, and then you retest. Really, really important is that retesting. Now, throughout the videos that I'm going to create in this series, we're going to look at all these different things. I'm not going through this with this video. I just want to show you one other example with this video on mistakes that are made in the medical field that we don't want to slip by. We don't want these mistakes to be made when you're looking at yourself from a functional standpoint. We'll have videos on all these different systems. In the autoimmune course, we go through number 12, in great detail. These are all things that you want to look at from a functional standpoint as a functional practitioner to help these systems work better. And we'll get in detail with videos on all these different things. Here's an example of a CBC. A CBC is a standard test called a complete blood count that's done typically if you go in for a standard yearly physical, or you go into your doctor and you're just not feeling well, or you went into the emergency room. This is actually a person that communicated with us a couple weeks ago, severe chest pain. I recommend that they go into the emergency room for the severe chest pain because there are certain tests that they could do in a lab that they could get back immediately, because most hospitals have a lab on staff, and they could get an LDH and a CK test if the person is suspected of having a heart attack, so that they would see that there's heart damage and they need to make appropriate action. They would get an EKG, they would do a CT scan, they have all these tools at their fingertips that I don't have, so get in there and get that testing done. Well, this person went in, this is part of just took a clip of part of their CBC. CBC, complete blood count, gives us white blood cell count right there on top, red blood cell count, hemoglobin, hematocrit, then it has breakdown of red blood cells, and then it also has breakdown of white blood cell percentage. And I pulled up this example because when I looked at what the hospital had sent us, I was a little flabbergasted, because this person ended up getting transported to a bigger hospital and getting their vessels scoped, and found that there was no blockage. They suspected blockage because some abnormalities on their EKG, but I just don't understand how something was missed. But let's just look at this white blood cell count portion here. The value is 12.7. Now remember I said that reference range. Now different labs might say optimal range. Different labs may say referenced range, like this lab. And those reference ranges can vary from lab to lab. I used this example before that some labs will have a reference normal, quote unquote, reference range for white blood cell count of 4.0 to 10.5. Some will have it 4.5 to 11.5. Well, this lab has 4.5 to 13.5. Well, I'll tell you right now that the functional reference range for white blood cell count is really about 4.5 to 7.5. If you have a white blood cell count over 7.5, there's something going on. So this lab didn't even flag that. So flag, when you look at a blood test, the flag means there's some abnormality. As you'll see down here, the MCH, the mean corpuscular hemoglobin, was elevated, and so it's flagged as high, H, and then a little elevated sign. So that's higher than the reference range. It's actually much higher than the optimal reference range. The white blood cell count, back on top here, 12.7, isn't even flagged because it's within their reference range. Again, a different lab may have 4.0 to 11.0. It would have been flagged as high. So this lab didn't flag it high. Thereby, the doctor who looked at the lab only is looking at those flags, saw there was nothing wrong with the person. Now, let's understand differential diagnosis. If the patient comes in with chest pain, what would you think of? Well, first you need to rule out heart issues, right? So remember I said there are certain blood tests that you would typically order right away. One would be a CK test, an LDH test. They didn't even run those tests. I'm like, what? I don't understand. Okay, then you think chest pain? Could this also person had some shortness of breath, heart issues, or lung infection maybe? You think possibly pneumonia? Okay, maybe. Functional range of white blood cell count, I said, is 4.5-ish to 7.5-ish. If you have an elevated white blood cell count over 7.5, you have to think that this person has an active infection. The doctor didn't even look at that. It was just completely ignored. First mistake. Second thing, this is the picture of the complete metabolic panel. There's some things that are elevated in this as well. I'm not going to go over that, but for the example, I just want to concentrate on that white blood cell count. So when I put this data that was done at this lab into our software, we get a different picture. It's a much prettier picture because it tells you in red what's abnormal. Total white blood cell count from a functional level shows you that you're highly elevated. So the functional level that our software gives is 3.8 to 6.0. If you're at 7.5, you're above optimal range, maybe not an infection, but remember I said if you're over 7.5, you definitely have an infection. This person definitely has an infection, completely ignored by the hospital because it wasn't outside of their normal ranges. Completely ignored though. But then you got to look at, okay, we know this person has an infection. Doesn't mean that they still don't have a blockage, and you still shouldn't investigate cardiovascular issues, which was done. All of that was clear for the patient. They sent the person home still having all the symptoms. I didn't get the lab work till several days later, looked at the lab and go, oh my gosh, you have an infection. You have elevated white blood cells, right? I don't know where they're at right now with the person, but definitely when they went into the ER, they had elevated white blood cells. And then you look at how the white blood cells break down. So the white blood cells are total white blood cells, total WBCs. And then white blood cells break down into separated fractions. You have neutrophils, immature granulocytes, lymphocytes, monocytes, eosinophils, basophils. So then we look at the percentage of those, and we look at the absolute value. That's the real number. So both percentage and absolute value are important. But the neutrophils are elevated. The lymphocytes are suppressed. Absolute neutrophils elevated. Monocytes elevated. This is a sign, and we'll go over this in more detail in further labs. I just wanted to show you this lab. This is a sign that because of elevated total white blood cells, this person has an infection. Now we go, is it a viral infection? Is it a fungal infection? Is it a bacterial infection? Typically with elevated neutrophils, it's going to be a bacterial infection. This person did go on through their doctor, not through the hospital, did go on an antibiotic, and they went over to the hospital still in all this pain, all this chest pain, still wasn't letting up, had a cough, all these signs of infection. Never was treated for an infection in the hospital, never was given an antibiotic in the hospital, comes home, goes on an antibiotic. In a couple hours, their symptoms start to subside. 2 days later, their symptoms are gone. This is, again, missing the functional ranges. So when you miss the functional ranges, especially in this case, which is fairly grotesque because the hospital's ranges are even even wider than a typical lab's function or normal quote unquote range. They missed the diagnosis. No, it was good that they tested. the arteries, that there wasn't any blockage. That really put the person at ease. They thought they were having a heart attack. They scoped the arteries. Everything was clean. Didn't have to do, any stent placement after the angiogram, which that's really great. That gave the person an ease as far as their anxiety, but it didn't solve the problem. They didn't dig any deeper. They didn't say, why is this person having the pain? Matter of fact, the doctor told the person that they were just having pleurisy, which isn't a disease at all, which is an inflammation of the pleural lining of the lungs. That's not really what they were having at all. Well, maybe they were having pleurisy, but the inflammation was due to an infection. So when you look at labs within a functional range, instead of the quote-unquote lab normal range, you pick up things that maybe your doctor's not picking up. So when you have done a CBC and a complete metabolic panel and you've been told that everything is normal, go home, it's in your head, go to a psychiatrist and get some anti-anxiety medication, maybe they're missing the diagnosis. So this person, serious pain, thought that an elephant was standing on their chest, pain, all because of an infection that was overlooked, was missed, because they were looking at the wrong ranges. Some of these things were even outside of their ranges and they just overlooked them, which I found that a little fascinating. Our software also breaks down the probability of dysfunction. In this case, with this person, with the limited labs we had, only a CBC with differential and a complete metabolic panel, which still was missing several components that we would run in a CB standard, wellness panel. It showed that 100% likelihood of this person having an immune function, meaning an infection, which was completely missed. And the person was sent home, told it was normal. Not good. Okay, so this software also tells you, here's the immune function, it explains it, and then it gives you the rationale on the right-hand side there. Well, your total WBCs, total white blood cells, were elevated. Your percent neutrophils were elevated. Your percent lymphocytes were suppressed. Your percent monocytes were elevated. Your absolute monocytes were elevated. And your absolute neutrophils were elevated. And then it also gives you biomarkers at the bottom in green that were not available in this test because the hospital didn't run it. It said ferritin would have been helpful to assess immune function. Well, ferritin, people think that is just an iron marker, but actually elevated ferritin levels do tell us acute inflammation too. So it would have been helpful to have that. That wasn't in the test that they ran. So this software also gives you the probability of dysfunction. I didn't tell you that the person also had elevated glucose levels. That's why dysglycemia is up there. But bacterial infection is 93% likelihood. Possibility of H. pylori if they're having gut issues also. But it was because, again, you don't just rely on the blood test. This is only telling us blood tests. You look at the person's subjective findings. They have pain in their chest. They have shortness of breath. They have a cough. And they had an elevated temperature for the patient. These are things that need to be looked at. If you're only looking at what is within the normal range given by the lab, we're going to miss things. I think we're called, again, we're called to study to show ourselves approved. That has to do with the Word of God, but that also has to do with the things that He's given us, and He's given us this human body to take care of. So this is the intro into these labs. We're going to dig deeper into the CBC and complete metabolic panel so you understand the values, so you can help yourself and your family as best as possible. So stick with us, and we'll make these available to everybody. Thanks.